So more recently, we got updated results at the EHA meeting and the 3-2 study. This is another important advance in the field because prior to this, if you had a patient who had progressed from the Murano study, we had the venetoclax and rituximab combination, which was fairly well established as a very effective salvage regimen for our patients. So the addition of pirtobrutinib to venetoclax and rituximab significantly improved outcomes, depth of response, and essentially patients were doing really well. And this was seen across all pre-specified subgroups, including patients who were exposed to covalent BTK inhibitor, including patients who were resistant or refractory to covalent BTK inhibitors, and then patients who had the high-risk del17P or TP53 mutation. So across the board, this combination was better as compared to venetoclax and rituximab. So PVR, as far as I'm concerned, if we are planning on using VR, I think it's very reasonable to consider the addition of pirtobrutinib in that setting to salvage those patients and hopefully have a much longer progression-free survival after time-limited therapy for these patients. And more importantly, it did not necessarily result in increase in the incidence of adverse events. Even the cytopenias were slightly higher, but not that significantly. When you look at febrile neutropenia, for example, tumor lysis syndrome, actually, if anything, is better. And we've seen this when you do a run-in with BTK inhibitors. The tumor lysis issues are much easier to handle and manage, and it makes it much easier to deal with those issues, and the monitoring of the patients become much easier. Atrial fibrillation is again consistently, we don't see this issue with pirtobrutinib, and also hypertension doesn't seem to be a side effect that we see with the use of pirtobrutinib, and that was true in the 3-2 study.